So I think next speaker is our Chief Instructor, ANSHUMAN. So ANSHUMAN, please join in. Again, he has very good experience in OT setting up OTs. Please join in, ANSHUMAN.
Thank you so much. Good morning, everybody. I've had the experience of setting up my own operation theatre for Sankara Eye Hospital at Bahrampur. So I've had all kinds of variety, and all of us out here can actually make a good OT setup without much difficulty. It's just a matter of following certain principles and allowing certain protocols to be followed all the time, extremely sincerely and with 100% compliance. That is the most important thing when it comes to the OT. It's a place of worship. You should treat it like that. I'm sorry, but Dr. Shailja couldn't make it today because she had a problem with her family and some problems in her own health. So I would be speaking about patient preparation etiquette in her place. Subsequently, I'll continue with the next talk. So we all want the operation theatre to be organized, not like this one on the left, but on the right side. So something that is not chaotic. Yeah, thank you very much. So we want all the OTs to be organized like this and not like this, definitely. So what are etiquettes? Basically, in principle, they are basically the set of rules that control accepted behavior in particular social group or situations. Putting it simply is that what all care you have to take, taking the circumstances and the social system that we have. So whatever is etiquette out here may not be applicable in America and vice versa. So you have to have your own set in our kind of setup, and if we have a rural or a urban setup, we have to make it accordingly. But following certain standard operating protocols that we govern and we make it. So why do we need these? Clear communication leads to enhanced efficiency. Enhanced efficiency leads to excellence and safety in patient care. Moreover, improved monitoring takes place during the surgery, and as a result, there's reduced chance of error. And all these things add up to make the OT running efficient and increase the cost effectiveness, putting your manpower and machine at the best place with least amount of utilization of finances and resources. So patient preparation etiquette involves various steps, as I would be going one by one: identification, documentation, preparation, transfer in, transfer out, and incident reporting. So identification is an extremely important step. The moment the patient walks into the hospital and goes in for an admission process, the first thing that should be done is identification tag should be put on the patient so that one knows that this is the patient who is planned for surgery. In that, it should be very clear his name or her name and the surname, the age, MR number or medical records number should definitely be allotted. If possible, it should also be clear at the onset only which eye we are operating. As we are all ophthalmologists, we should be on that. And there are different principles followed in different OTs and different admission systems, but generally what is done is a red band is put in the right hand and a blue in the left hand. But most important thing to understand is that you have to make a standard operating protocol, and everyone in the staff from A to Z should understand it, so that whenever you find that there is a place where there is likely to be an error, one or the other person can point it out without any fear or any loss of faith. So again, check for any allergies and also check out how the patient is behaving on the day of the OT. Is he hearing properly? Is he a very old man? Is he somebody who's frail, who's not able to understand? Or he's from another region and is not able to understand your language? Because most of us now are switching over to topical phaco, and even with giving an injection phaco, local anesthesia phaco, we need to talk to the patient many a times during the surgery. Informed consent should ideally be always given a day in advance so that the patient goes through it, sees all the pros and cons of surgery, all the complications involved, and sign it knowingly, and that's why it's called informed. But then on all practical reasons, it may not be possible, but the most important thing to understand is please get the consent signed before you take up the patient on the OT table. That is 100% yes. If you haven't done it, you are in big trouble. The other things that you need to check out is the investigations and whether they are under normal parameters. If a patient is there who's likely to have a raised blood sugar or something, you should do a blood sugar at the time of entry of the patient and recheck him. In case a patient is for general anesthesia or a child, then or a disabled patient or a mentally retarded patient, special care has to be taken. And those patients who are going in for anesthesia, general anesthesia, definitely a pre-anesthetic checkup is a compulsion. So the other part is that you see the gait of the patient once the patient walks into your OT complex, because you want to see if there is any other problem the patient might be having. Is he too drowsy? Is he having a gait which shows that he can't lie down properly, or he's got spondylosis? Because these are all going to affect the surgery ultimately. And there are cases where people have seen the patient is so anxious the night before that he hasn't slept, and he's so sleepy that while doing the topical surgery, they fall asleep and they lose the ability to remain straight. Other thing that needs to be seen is patient hygiene, whether he's clean or not in the facial area, at least with his eye surgery. If he isn't, then he can be asked to wash his face with soap and water. How is his otherwise sensorium? Is he claustrophobic by nature? Then one more thing that is often followed in most of the OTs is that we change the street clothes to OT clothes. But yes, some people in the process of modernization don't do that. But every hospital has its own rules, and I think one should have a standard protocol on that. The other thing, especially related to patients, lady patients who wear a lot of jewelry and all that, their jewelry should ideally be taken off at the time before the surgery. But in case they are not in a position to be taken off, because many times the screws are very tightly put, then in that case, cover it with a micropore. In the case of those people who have a hearing aid problem, if the surgery is on the same side, the hearing aid should be taken out, because many times fluid can go in and spoil the hearing aid. If it is on the contralateral side, then you can keep it because it helps in the communication. The same goes for ladies with buns. The buns should ideally be on two sides so that the big bun doesn't impinge on the head and disturb the patient. Again, dentures are absolutely a no-no. All old patients should be asked whether they have dentures or not, because it's a very big source of having a blockage of the airway while the patient is lying down. So again, coming back to basics, checking the hypertension of the patient, whether they have taken the medication in the morning, if they're a diabetic, if they have taken the medication, have they taken any food along with that, have they stopped their blood thinners, and so on and so forth. And the local examination is extremely important. Check both the eyes. Even if you have redness in the contralateral eye or a secretion, you should be very careful, because we can have a spread of infection from one eye to another. Then going back to the general checkup, again, BP, SpO2, blood sugar, all these are checked. Patient is put in OT clothes, cap and shoe masks are given, and IV line may be put depending upon the situation. Any allergies should have been noted preoperatively, and in case it hasn't, it's not a bad idea to recheck once more before you start dilating the patients. Some patients who are hypertensive, it will be better to use a drop without phenylephrine. And anesthetic drops, again, you have to use Paracaine, or depending on if you're doing a local anesthesia, injectable, you don't need to do that. One more principle that we most all follow is we apply povidone iodine 5% 5 minutes before the commencing the surgery to sterilize the area. Other than preparing the patient, the OT area should also be nicely prepared for the surgeon. For instance, that whatever you are implanting the IOL, maybe at least those IOLs and a backup IOL should be there. And if the case requires specific changes, like for instance, special viscoelastics, dilators, anything like that, they should be available as per the case requirement. Children, physically handicapped patients, of course, have to be taken with extra care. Those with HIV, you have to take extra care that you don't get infected by them and the staff doesn't get infected by them. If a patient, now this is one thing that a lot of people neglect, if a patient is for any reason cancelled or rescheduled, please do not neglect the patient. Explain to him why it has happened and when is his eye surgery going to take place later on. Because many times you just forget about him that, oh, the OT cancelled, let him be sitting there and tada bye-bye. So that should not be the type of attitude that we should have. Okay, Now, there are three processes which are followed more or less because of NBH now, and it is a very good process. Is basically we do what is known as sign-in, time-out, and sign-out. Sign-in is at the time before anesthesia. This is the time when all the staff, anesthetist, surgeon are around the patient. Each one of them is given a call, and a kind of attendance is taken that all are present in one place. And preparation for giving the injection, if you're giving a local anesthesia, takes place. Incision, at the time of incision, just before starting, is known as the timeout. Again here, the nurse out there, she checks out whether all the surgeon anesthetists are around and everything is nicely prepared or not. And the last step is sign out. When the surgery is over, in case of other surgeries, you check for like gauges and all that, but in eye surgery, we don't do that. But we see that the pad bandaging is done properly, the eye is nicely closed. If you're doing topical, the patient closes his eyes properly without any difficulty, and a discharge note or a post-operative order is given at this stage. So sign-in, as I said, in peribulbar block, you should have preferably a crash cart, which should take care of any adverse events during the injection process. And of course, you should take care that whatever drugs you are using are not expired. And before giving the block, of course, check the identity of the patient and the eye that is being planned for surgery. Because these are places where errors take place, and many times it happens that the block is given in the wrong eye and the surgeon also operates in the wrong eye because he sees the block in that eye. So this is a very big point of error which should be extremely carefully handled. So of course we have the standard method of draping, and I think all of you know how it's done, so I'll just skip through this more or less. But important thing to understand is if you have a situation where the patient has a breathing problem, it would be nice to have a tent over the face so that the tissue or cloth falls over the nose area. And finally, of course, the draping of the eye is done with a sterile steri-drape, and incision is made very carefully. Again, out here, the incision should be made very carefully and taking care that you don't traumatize the eye or the lids, which have happened with certain surgeons, so you have to be extremely careful. So your staff or you, whoever is doing it, has to take extreme care that you don't cause any damage to the tissues underneath. There are certain standard charts which are available from WHO which tell you a kind of a checklist, what all you need to do before at the sign-in, time-out, and sign-out. And this is available on the website of WHO, and you should be able to follow it. On the surgery table, very important to have a surgical safety checklist. The part of the checklist is made preoperatively in the OPD area where the surgeon writes down the eye to be operated, the type of cataract, how much is the hardness, what special care you have to take, is the pupil nicely dilating or not, do you need to have any other viscoelastic or a pupillary dilator for it, and any other factor like a deep set eye or something, or spondylosis or something problem where the patient cannot keep his head straight on the bed are noted down. And this checklist should be there beside the surgeon on the OT table so that when he sees the patient, he has to first recognize the patient and check out what all is required. So again, in the transfer out portion, basically the patient is shifted out, checking that all is well, and the post-operative advice and discharge are given. Important thing is, last but not the least, is incidence reporting. This is an extremely important step that all of us should follow. It should be a no blame game system where you don't blame anybody if that person is blamed, has made a mistake, because they will not come out with their faults or what they might have made a mistake unless and until you have this policy. So just allow them to say if they have made a mistake and correct it, and do a root cause analysis later on and bring about changes in your protocol so that it doesn't get repeated. And this is the final slide on the process map they follow. Thank you so much. I hope I didn't take too much time. Thank you very much. I'll go on to my next topic. Any questions? We can have it at the end, I believe. You can just make a noting of it. Okay, So, ready? Thank you. So this is another extremely important part of OT training, which we unfortunately never learn during our MS days. We are all peeping into the eye, looking into the eye, treating the eye, but when it comes to handling the OT or the instruments, we know nothing about it, unfortunately. So I have no financial interest in any of the products that I show here. But yes, I am extremely thankful to all the staff and seniors who taught me in the process over the last 10, 15, 20 years how to handle the OT instruments, how to clean them. It's a learned process. You learn it from many people, including